Good evening, everybody. Welcome to the May 17th installment of the Trauma Nursing Journal Club. I'm glad you can join us tonight. My name is Steve Weinman, and I am with the trauma program at St. Joseph's University Medical Center in Paterson, New Jersey. At St. Joe's, I serve the role of trauma education and injury prevention coordinator, and I have nothing to disclose for purposes of continuing education tonight. So, just wanted to do a quick shout out to the two components that make up the Trauma Nursing Education Series. There is obviously tonight's Trauma Nursing Journal Club. It's a quarterly meeting where we go over pertinent articles that appear in the literature and that pertain obviously to trauma. And then on a quarterly basis, we do what's called topics in trauma nursing. And topics in trauma nursing is just pretty much a straight out talk of a trauma topic of interest. So we'll talk about that a little bit more toward the end as to what our next installment of trauma nursing topics in trauma will be. So we do have some loose goals or rules of Journal Club. First is that we do review current literature as it pertains to the practice of trauma nursing. We like to promote an evidence-based trauma nursing practice model. We like to foster ideas for possible research papers for publication down the road. If you're working in a trauma center or an emergency department and you see something here, maybe it will germinate an interest in coming up with something for future research and presentation and publication. Obviously, professional socialization amongst like-minded colleagues, and that's really how Journal Club does go. This recording is done without the interactive component. When I do Journal Club as part of a local education endeavor, there's multiple people on a Zoom meeting, and we do definitely get some professional socialization here. But hopefully by your participating or looking at tonight's broadcast, there's a certain amount of socialization that is happening, and certainly you can feel free to communicate to me via email with any questions or comments or feedback that you may have. And last but not least, I hope you kind of enjoy tonight's talk. The paper I selected for tonight actually ends up being very timely. We'll talk about that in a little more detail at the end, but the title is Prehospital Shock Index Outperforms Hypotension Alone in Predicting Significant Injury in Trauma Patients. This is a great article in that the title pretty much tells you everything you need to know about what's in the article, right? No need to read. Time to move on to the next article, right? Well, yeah, we wish, but no, it's good to kind of get into the nitty-gritty of why they state that as their intended title. This is put out by the folks in the Department of Surgery at Brown University at the Warren Alpert Medical School there in Providence, Rhode Island. So shout out to Kheirbek et al. For putting together what I think is a pretty decent article and a very timely article that I'll keep saying throughout the talk, and you'll see toward the end why I'm saying this. This particular publication is from Trauma Surgery and Acute Care Open. It is an open access medical journal, online medical journal, put out by the British Medical Journal. So if you go to tasco.bmj.com, you will actually get access to all of the articles that are published through Trauma Surgery and Acute Care Open. And it is absolutely a phenomenal online resource. I've served as a peer reviewer for a couple of years for the publication, but I was an avid user of the publication prior to picking up any extra responsibility. So let's talk a little bit about what the paper gets into, and we'll kind of walk through it a little bit, and I'll just kind of give you my perception of some things. These are just my opinions. Read the paper on your own if you want to get the full impact of everything. I'm just going to kind of distill it down to you in about 20 slides or less. And again, it's my interpretation. It's the way I'm looking at things. We all look at things a little bit differently, so please take the time and do so on your own. So for tonight's article, really the authors came up with the fact that prehospital triage is critical when it comes to determining in the prehospital setting appropriate trauma center routing. And then once routed to the trauma center, what level of trauma resources may be needed within the trauma center upon arrival. Every trauma center has their own gradated system of how they respond in-house to a trauma, depending on what the mechanism of injury may be, the physiology, or the anatomical distortion. That all comes out of the American College of Surgeons Committee on Trauma trauma triage program. This was last updated in 2011 and published in early 2012, and is a little bit on the antiquated side, but good news is I've got some good news toward the end, so that's all I'm going to say. But this is kind of the basis by which right now throughout the United States that trauma triage in the pre-hospital setting is carried out. And it is carried out basically along the lines of 3 items, which I already mentioned: physiologic abnormalities, anatomic abnormalities or injuries, and then ultimately the mechanism of injuries we can see from our little buddy here at the bottom. The trauma triage guidelines is then distilled, and there is an algorithm that is available that pre-hospital clinicians can use when it comes to grabbing and then looking at their patients, doing initial primary and secondary surveys, and then ultimately deciding if a trauma center is warranted, and if so, what would be the basis by which they would want to transport to the trauma center. For the trauma center, what it really kind of does is it helps then distill based on physiology or physiologic abnormalities, anatomical abnormalities, or mechanism of injury. It allows them to decide what kind of resources they want to put into practice at that facility. From the standpoint of what we look at now, and what this paper looks at, is they look at, is a systolic blood pressure indicating hypotension, which by definition here is less than 90 millimeters of mercury in the adult population. It's a little bit different for geriatrics, and we'll talk about that more toward the end, and it's a little bit different obviously for pediatrics. But in the adult population, adolescent or preteen, teen, or teen, through geriatric through about 65 years of age, hypotension is defined as a blood pressure of less than 90, and that's one of the higher physiologic triage triage characteristics that pre-hospital clinicians look at. Within my trauma system at St. Joe's, anything that kind of meets any of these ardent physiologic criteria are typically going to be higher order injury cases, we believe, and that we're going to pull out all the stops and do a full trauma team activation for that individual. And that's, in our institution, a trauma code is the highest order of trauma activation. It brings every trauma resource that we have in-house virtually to the bedside, because these are usually the sickest of the sick trauma patients. But this trauma triage routing is critical because depending on how accurate trauma triage criteria are, and these patients being routed appropriately to trauma centers, it can make or break from a financial standpoint how you handle things within your trauma center. To do a trauma code is more costly for my hospital than it is to do a trauma activation or a trauma alert, which is kind of our middle tier, and both of those are far more costly than a trauma consult, which doesn't bring the resources to the bedside in an emergent fashion. So certainly part of this paper and part of what the authors are trying to do with this paper is really determine, how good is the systolic blood pressure at 90 at determining severity of injury, and are we over triaging as a result of using this systolic blood pressure? And we'll chat about that. So let's talk a little bit about the issue with systolic blood pressure of 90, at least in the eyes of the authors, and certainly I think it bears out in some of the literature, which is referenced at the bottom of this page. First of all, it's an arbitrarily selected number. There is no real evidence that supports that systolic blood pressure of 90. What we think about 90 or 90 to 80 as some places are, is this is the amount of pressure that is needed to perfuse the brain, the heart, the kidneys, the liver, things like that. I mean, and it makes sense, and we think anecdotally we've got certainly years and years of experience, says that probably holds true, but there isn't nothing ardently in the medical literature that says we've researched this and this is the cutoff number. So it is a bit arbitrary. And because of that, there are adults who walk around normally with a systolic pressure of 90. So if that normal adult who maybe is very athletic, or maybe it's a person who is a small frame and smaller stature, if they come in and they've got a blood pressure of 86, and that's baseline for them, which it is for some people, or for people who maybe are older and have physiologic derangements that they live at a blood pressure and they do perfuse at a blood pressure that is lower, it can be a little misleading, because we can inadvertently be routing them to a trauma center and more ardently putting them through the highest level of trauma activation for something that really doesn't need to be done. So again, it's, you got to look at things, and you also have to look at the fact that hypotension can be due to other causes. we think about hypotension in the trauma patient, we think about hemorrhage, right? But the reality is that could it be a vasovagal response? How many times have you had somebody, they injured themselves and the sight of blood caused them to have a vasovagal response, and all of a sudden they're dropping with a pressure of 80. It's a transient drop, but gosh, they had a systolic blood pressure of 80, and according to the trauma triage guidelines, we got to route them to a trauma center and maybe a level 1 trauma center. So again, there is, systolic blood pressure alone is fraught with some issues. The method of obtaining the blood pressure is also sometimes under consideration. Are we using auto cuffs? And we know auto cuffs, particularly in ambulances, can be notoriously off base. So, are we manually cuffing them? Are these manual cuffs calibrated to the extent they need to? Is the right cuff size and placement being done? And of course, there's clinician variability in how they obtain blood pressures. And, again, this is not to pick on the pre-hospital colleagues because you guys do a great job. You guys do a great job out there. This also holds true for in the hospital setting, but we don't have equipment that's being jostled around quite as much in a trauma bay or in an emergency department as you have in the back of a box. So those things have to kind of be considered when we're looking about strictly systolic blood pressure of 90 as a sole indicator. So good thoughts there, I think. And then they talk about the shock index. So let's talk a little bit about the shock index, okay? The shock index is pretty straightforward. If you haven't heard about it yet, I'm glad you're listening in because you'll hear about it tonight, but it's very simple. It's the heart rate divided by the systolic blood pressure. And typically, and there's some numbers there that kind of, from the literature that talk about shock, no shock, mild shock, severe shock. Look, shock. Shock is shock for the purpose of what we're talking about tonight. If you've got a patient, they're injured, and they are in shock, whether they are compensatory or uncompensatory, you know what? They're in shock, and we have to deal with them. And we want to figure out as quickly as possible that they're in shock and start treating them appropriately, right? And the shock index does a nice job of doing that. The good thing about it is there's a growing base of evidence that really supports the shock index. And the shock index basically says is if you take the heart rate and you divide it by the systolic blood pressure, and if it is 1 or greater, then the patient has a high likelihood of either being in shock or heading very quickly towards shock mode. Anything that is less than 1, 0.8, 0.9, 0.6, not so bad shock or not shock, and certainly anything greater than 1, again, the higher you are over 1, the more shock you're in. We use 2 physiologic parameters. We use heart rate and we use systolic blood pressure, not just systolic blood pressure alone. And in case you're wondering, yes, there is a pediatric shock index as well. And pediatric shock index, again, is age-related. It's a little bit more gradiated. Less research done on the pediatric shock index versus the adult shock index, but the regular shock index. And shock index is not only a hypovolemia trauma type shock thing. It's used for a variety of shocks. It can be used for cardiogenic shock. It can be used for distributive shocks. It can be used in sepsis, things like that. But there's a growing body of evidence that really shows that this is a pretty reliable indicator, and maybe this is something we need to be considering when we're thinking about trauma triage, both pre-hospitally and even in the hospital setting. So the author's hypothesis basically was that an elevated pre-hospital shock index, so a shock index of 1 or greater, is going to be better associated with significant trauma injuries than pre-hospital hypotension alone, or a systolic blood pressure of 90 or less. Therefore, it's going to be a better indicator of when to trigger the appropriate trauma team response within a trauma center. Okay? And this even can extend back, even though it's not the purpose of this paper, but it can extend back into the pre-hospital setting of, whether or not we even route the patient to a trauma center, because maybe the injuries aren't so bad and that they don't need to be routed to a trauma center if they've got a shock index of 0.6. Okay? So something to think about. But for the particulars of this paper, they really wanted to test and see if we use the shock index, will it be better at really catching patients or predicting significant injuries than hypotension? So what they did is they did a retrospective cohort design. So they really went back into their trauma registry and they pulled out patients that met a variety of criteria. Time span was really over. It's supposed to be January of 2020. It's a time span of about 2 years. Their inclusion criteria is because they were really looking at some cost savings or some cost methodology here. They were really looking at it for those cases of pre-hospital hypotension that triggered the full trauma team activation, or their highest level of trauma team activation, which in their facility was a level A trauma team activation. They excluded anyone who came in as a transfer, and they also excluded anyone, rightly so, who was missing vital sign values of either heart rate or blood pressure, because you wouldn't be able to calculate, and even retrospectively, a shock index on them. It did go through the nominal IRB approval for the institution. So the authors were really interested in this association between the physiologic metrics, again, heart rate and blood pressure, or blood pressure alone, in the presence of serious hemorrhage and serious injury in general. So what they did is they pulled together a number of items. They called them composite items. And these are items, or these would be, in retrospect, through their trauma registry, injuries that have a high risk for hemorrhage. And therefore, if one of the indicators, either shock index or hypotension, didn't catch the injury or didn't predict the injury alone, then it was a compounding factor. Then they also looked at a couple of secondary factors, such as the need to go emergently to the operating room, the need for transfusion within the first 24 hours, death in the emergency department due to trauma, or just generalized in-hospital mortality, in-hospital death. And they looked at all of these composites and these secondary inclusion criteria, and then these are the things that they looked at numerically that went into some of their statistical computations to determine whether or not what they found was significant or not. And again, for the purposes of the study, hypotension was defined as a systolic blood pressure of 90 millimeters of mercury or less, and the shock index was 1 or greater. This is the statistical analysis, and like my buddy SpongeBob over here is, it just kind of makes me want to yak. So they went through really what I think are the other nominal statistics that you tend to see. They used a statistical software program called Stata, which is pretty universally used. And then they were able to plug in a variety of values and do computations using things like a student t-test, Pearson's X squared, and Fisher's exact. They did some logical regression, blah, 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 Mann-Whitney. I mean, they did all of these things. At the end of the day, they were able to feed all of this data in and computate whether or not their findings were significant. And by findings of significant is, did what they were looking to do actually turn out to be true? And for that, they will answer that statistical significance in what's called a p-value. And a p-value in almost every study that I've ever seen, if it's less than 0.05, so it's like less than a 0.05, or I think that's a 5% chance that this is something that happens just through random happenstance in the universe, then it's statistically significant, and then the hypothesis may be true. In this particular case, if they found a lot of variables in favor of shock index versus hypotension alone, with p-values that are 0.05 and below, then they're significant enough to believe they may hold truth. And maybe you should start believing them, or maybe some additional research needs to be done to look at things a little bit more deeply from a belief standpoint. So that's going to be really my talk on statistics for the night. Again, I'm not a statistical guru. I know just enough to know what a p-value is, and I think I'm like a lot of individuals, a lot of medical individuals who read the literature, a little scared of statistics, even though I did actually pretty well in college with them, but the information just didn't stand around. It's the math part of my brain which just never worked. So here's what they did. They went through the trauma registry and they identified, we talked about the inclusion criteria a slide or two ago, they identified about, a little over 1,000 patients. They excluded patients based on the exclusion criteria of traumas or missed values against systolic blood pressure and heart rate. Sample size came down to about 544, almost half of what the original patient load was. Of that 544, only 247 were included, and that was based on that composite outcome scoring. That was based, remember, we looked at a couple of slides back, that was things like those composite injuries that would result in hemorrhage, things like liver injuries, spleen injuries, pelvic fractures, long bone fractures, things like that, and then also the more direct data, such as immediate need to go to an operating room, blood transfusion, death in the hospital, things like that. So here are the results, and I'll go through these, kind of try and refer back a little bit to the chart, but really I think the bullet points stand on their own. So when they looked at hypotension with significant injury versus those patients that came in normal tensive, which meant they had basically a normal blood pressure or a systolic blood pressure greater than 90. They found that even though 82 patients were hypotensive, 247 had significant injuries. So when you look at that number, the 82, not even probably about a third of the patients that came in that were hypotensive had actually significant injuries. So hypotension alone only hit it about 33% of the time, which is not very good statistically. Again, that meant 66% of the patients had significant injuries, never even displayed hypotension. Interesting, right? There was no statistically significant association between hypotension and the need for hypotension on whether or not the patient had a significant injury and whether or not there was a need for transfusion. So whether they were hypotensive or normotensive, again across the board, there were numbers that were statistically unequivocal with regards to the overall injury patterns, and then whether or not the patient needed a blood transfusion. Of those that survived in the emergency department, hypotension was not associated with the need for emergent operation. When you look at someone who was hypotensive versus someone who's normotensive, about 36% of the time they had to go to the operating room versus about 30% of the time, according to their data, the normotensive patients who had serious injuries had to go to the operating room. And then mortality was really no different. So whether you came in and you were hypotensive and ended up dying, or you came in normotensive and ended up dying, the two were about the same, so they were not significant. That's what the NS really means. The only thing that really was significant, again, was just the normotensive patients who came in and really had significant injuries. And basically, based on this data, they were able to start kind of formulating a conclusion that the significance of hypotension is really a poor predictor of overall serious injury. It only caught 33% of those patients that needed injury, and at the end of the day, no more people died that weren't hypotensive that were hypotensive. So certainly something to think about when you're going forward and thinking about using hypotension only as an indicator. And again, the authors found that using hypotension alone resulted in about a 57% higher level trauma team activation, or an over triage to higher activation. Now, it doesn't mean it was an over triage to coming to a trauma center. Certainly, if you're hypotensive in the field, then yes, you probably should be routed to a trauma center, given the current trauma triage guidelines. And so they weren't over triage in general, but it meant that, based on what they saw, 57% of the time, those individuals coming in that they were activating their higher level trauma team, more expensive trauma team for, didn't need it. And again, so it can be some significant savings. They didn't go and put any kind of a cost savings, cost benefit analysis in here, which would have been interesting to see. So let's look at the shock index, and they look specifically at shock index of greater than 1, so 1 or above, or a shock index of less than 1, which would be 0.9 or less. And what they found, again, was a contrast to hypotension, and that those individuals who had a pre-hospital shock index of greater than 1 had a higher rate of significant injury, need for transfusion. They were more likely to die in the ED or need emergent operation versus those that had a shock index of less than 1. So if you look at the significant injury bar over here, you can see statistically, again, 0.04, you had a 54.6%. Remember, 33% in the other. So I mean, it's not quite double, but I mean it's significantly higher. Fortunately, there was no difference in hospital mortality, which was a good thing. But the significance here across the road was that for significant injury, transfusion, death in the ED, and emergent operation needs, is that across the board, the shock index of 1 or greater was a better predictor of needing those resources. Ergo, something to consider. So maybe the hypothesis might hold true. Then they plotted out some additional data to look at some stuff and look specifically at significant injury and then the need for transfusion as two of the variables they looked at. And while shock index outperformed hypotension in predicting both severe injury and the need for transfusion, the real difference was only significant for transfusion in this one variable they looked at, which you see in this graph here. If you look at the significant injury, it still edges out hypotension, but certainly statistically not as significant as it does in this graph over here. The p-value that they used here when it came to need for transfusion between the shock index and hypotension was a p-value of 0.0001. That's actually fairly significant. Okay, so again, they're mounting some good data that shows within their own data set that they're looking at that shock index certainly is outperforming hypotension alone. Then they did a couple of additional analysis, and without getting nitty-gritty on this stuff, what they saw was that when somebody came in with an elevated shock index, a shock index again greater than 1, there was a fairly specific prediction of significant injury. So they found that it was 61%, or almost 62% when the patient came in with a shock index of 1 versus almost 44% with a shock index of less than 1, which is again gives us a p-value of 0.03, which again rises to statistically significant between the two, and especially when you compare that back to predictor of significant injury with hypotension, which was about 33%. And then using stepwise logical regression, they were able to show again on a graph format that really patients who came in with significant injuries and an ISS greater than 16 is really moderate and you're heading towards severe injury. Again, the shock index was a better predictor of all three. And all three here was significant injury, the possible need for transfusion, and then modeling that these patients will end up, at the end of the day, end up being more severely injured than not. From the standpoint of discussion, they then went in to talk about the fact that pre-hospital hypotension, based on the data that they were able to glean from their study, was not a very reliable predictor of significant injury, nor the need for transfusion or operative interventions or mortality. That an elevated shock index, again, greater than 1 or greater, was more reliable in predicting all 4 of these aforementioned criteria. They also went on to say that, a single physiologic metric, systolic blood pressure in and of itself, is a pretty poor predictor for resource needs of the trauma patient. It was evidenced by the fact that I think it was 57% of the hypotensive patients that came in didn't really need the higher level of trauma activation that was going on at this particular trauma center. And they felt that in order to minimize over and under triage, a more refined pre-hospital triage metric needs to be put in place that will take into account the fact that, besides looking at one non-reliable physiologic criteria, should we be looking at several? And, they bring apart, I think, a very good point by doing that. At present, when we look at trauma triage guidelines, there's 3 main criteria that we use to trigger trauma triage routing. And again, that's that anatomical consideration, physiologic variables, and then the mechanism of injury. And then there are some special considerations for the pregnant patient, for the geriatric patient, for the pediatric patient, for the burn patient, things like that. But really, you're talking about anatomy, physiology, and mechanism as your main 3 drivers. And historically, we were using a systolic blood pressure of less than 90 to predict or to route trauma patients to higher level trauma care, and then when they came into our trauma rooms, putting them at probably the highest level of trauma we could give them, based on the fact that these are the sickest of the sick, and maybe they're not always. We also need to look at does one episode of pre-hospital hypotension constitute a clinical decision-making tool? The patient had transient hypotension for some unknown reason in the field, but was normotensive prior to that hypotensive episode, had maybe a 5-minute hypotensive period, and then recovered back to normotensiveness. Is that really, does that really mean anything? And they're not really sure. They don't think so. The data is certainly not showing it, at least in this particular cohort study, but you never know. And of course, they kind of walk back to the fact that, hey, guess what, guys? At the end of the day, a value of 90 is pretty arbitrary, and there isn't a big evidence base to support this number. Why are we using it? And, oh, by the way, the shock index has, half a dozen to maybe 10 studies that really show that it can be a pretty good predictive tool, or at least a useful tool from a screening standpoint. Why aren't we thinking about that? And, always remember, there's also confounding variables dealing with any patient. When you're using heart rate and systolic blood pressure as your physiologic markers, there's a lot of variables in what a patient can be doing or taking, or how their exercise routines are, or what their comorbidities are, or what medications they're taking, or how old they are, that can impact how the body responds from a heart rate increase or decrease, or a blood pressure increase or decrease. And again, these are all variables that we have to kind of consider, and I think we often do consider, which is kind of why we have kind of the special considerations for particularly the geriatric patient, where we're looking at a higher marker for hypotension, which is a marker of 110 millimeters of mercury or less. So as with any study, there are some limitations here. It is a retrospective design, as we know. Prospective studies are the best to go. Systematic analysis, systematic studies where they have meta-analysis, which basically means you take a lot of studies from a lot of different institutes which really look at the same data typesets, and you combine them together to see if there's similarities across all of the studies. Those are the higher order tests, so a little bit of a retrospective design. It gives us enough information to where we can say, hey, I think we're onto something. Let's do something a little higher order. Or maybe somebody else will do it. Again, it was that single institutional cohort. So, there could be, again, some biasness that gets interjected into the way the patients were selected. When it's done across multiple institutions, there's a little bit more heterogeneity, if you will, to the patient cross-sections that they're looking at. Certainly, it's possible that some of these patients that were hypotensive weren't hypotensive. There were some inadequacies in blood pressure medicine, and I think that that's possible. Is it likely? Yeah, I don't know. I spend a fair amount of my time in the pre-hospital setting, and I've seen it a lot where you get a new EMT and they're getting a pressure that's just weird, and then you go and it's a completely different pressure. And so if that's the case and it's a month out and that same newbie EMT is still kind of having issues with hearing a blood pressure in the back of an ambulance, then is that becoming problematic? And it may for the study. They only looked at level A activations. I would have been interested to see what happened if they looked at across the spectrum and compared the same data for their level B activations. But my sense and sensibility is that because the criteria of 90 millimeters of mercury was part of their high criteria, that they probably didn't have a large number of level B activations that would have probably enhanced the study very much. And there were other things like, vital sign data sets that could have increased the study pool, maybe looking at respiratory rate, things like that. But again, I don't think that necessarily was a major limitation to this study. And the composite injuries, they identified these composite injuries that had the potential for being serious injuries or being very hemorrhagic injuries. But not all of them probably were. In fact, we know that most liver injuries are usually non-operable. And are just basically treated conservatively. So looking at all of these liver injuries, and did we kind of pull out those that didn't have that didn't have serious, like grade 3 liver injuries and above, and was that a confounder when it came to looking at the data? And it very well likely could. So their conclusion, based on looking at their data, going through all their statistical analysis, really was that if we want to really minimize over and under triage, particularly with how we activate our trauma teams within our hospital, that something probably needs to be done with looking at systolic blood pressure alone. Again, the data does suggest that a shock index of greater than 1 seems to outperform hypotension alone as a predictor of significant injury, and that the American College of Surgeons Committee on Trauma should consider replacing hypotension with shock index as a metric for higher order trauma center routing and or trauma team activation within a singular institution. And consider that an elevated shock index is an additional screening tool for patients who do not meet current physiologic criteria to decrease under triage. So currently, where the current is just looking at 90 millimeters of mercury, should we be augmenting that and also looking at shock index and maybe comparing the two, which I think, again, is not a half bad idea. So because timing is everything in life and sometimes in death, last week the American College of Surgeons released revised trauma triage guidelines for the pre-hospital setting. And they are a fair of a departure from what we have been using since 2012. In particular, and oh, I'm going to go back. The paper is actually available. If you're going to let me go back, you're not going to let me go back, are you? All right. The paper is available online. And if you basically just Google, field triage guidelines 2021, I think you'll end up getting this paper. Again, the paper is on trauma surgery and acute care open, and it really is a decent paper. And really what they've done is they've really kind of distilled some things around a little bit. And gone is that kind of that four-tiered algorithm that they have. And now they've just kind of separated things into high priority or red criteria and moderate risk or low or yellow criteria. And they look at injury patterns, okay? They look at mentation and vital signs. And this was formerly called physiologic criteria, but now they've gotten away from that terminology. They still do look at mechanism of injury and injury patterns and such, but they don't call it that anymore. So really, injury patterns would be the old anatomical. Mental status and vital signs would be more toward the physiologic side. Mechanism of injury would be, well, what it has been, the mechanism of injury, and there have been some changes there. And EMS judgment, expanding the use of when EMS clinicians can, route to a trauma center because either there's something going on with the patient or they got that gestalt that maybe they can't put 100%, put data to it based on, assessment, but there's just something there. With the caveat, when in doubt, route to a trauma center. And it's really beyond today's talk to go into this in any detail, but suffice it to say, there are some pretty significant changes here. One of the most significant changes is, guess what? They added the shock index. So coming soon to pre-hospital triage near you will be under this mental status vital signs category. You see they still do have systolic blood pressure grade less than 90 in there, less than 110, remember, on your elderly patients. But now they've also incorporated the shock index. So use it in as its own. But again, if heart rate is greater than systolic blood pressure, which mathematically is always going to be a shock index greater than 1, then these are patients that probably you want to consider routing to a trauma center. And they are under the red criteria for the most highest risk for serious injury. And there are other things in here that make for very interesting reading. So again, if you have an interest in pre-hospital care, if you have an interest in trauma triage in general, if you're working in a trauma center, then this is a paper that is probably one of your must-to reads over the course of the next few months. It is put out by the American College of Surgeons. They are calling these national recommendations. So what does that mean? It means that they will eventually become standard of care. But it's going to take time, since every state is going to have to look at these and are going to have to adjust their trauma triage criteria if they haven't already done so proactively to make this work. And this is just the old versus the new and what you see. And again, it's felt based on EMS clinician review that the old trauma triage guidelines on the left were a little bit cumbersome to use versus the ones on the right are a little bit more cut and dry. If you fall under one of these red criteria, then you go to the highest level trauma center within your region. If you follow a yellow criteria, then you go to any trauma center within your region. But nonetheless, then trauma centers can say, well, red criteria coming in, we're going to activate our highest level care. Yellow criteria coming in, we're going to activate our second tier response, if the case may be. All right, now, of course, we're recording this, so we're not going to have the ability to have open discussion because there's no audience here tonight. But think about to yourself, ask yourself some questions with regards to what you saw and what we heard about. The group that's going to be coming on when I do this in my normal fashion, they've been given a copy of this article. They were supposed to read it prior to coming on the session, which is going to happen in about a half an hour, and we'll discuss it. Can't really do that here, but I thought it was important and timely because of College of Surgeons bringing out the newer recommendations for pre-hospital triage that I get this out there. And even though you can't do a lot of discussion, there's some stuff you can think about if there are questions that you have after listening to this and watching this, or you read the article and then watch this again continue to have questions or want to disagree with me on some stuff, which is cool, then yeah, reach out to me. You know, I'll certainly give you my email address momentarily, and you can reach out to me. For the people that are watching this live, there's actually going to be some CEs that are available. Sorry, you can't have them online, but yeah, at least you got some good information, right? But I do put up there that we will be posting a video somewhere around June 8th. For topics in trauma nursing, we'll actually be doing a talk on damage control and resuscitation. That'll be done by Kathleen Robinson, who is the Director of Operations for the Emergency Services line at the Robert Wood Johnson part of its health system here in New Jersey. And I sat in on this talk at New Jersey State Council of ENA's fall or spring meeting, and Kath did a phenomenal job. So I've invited her to come and do it again, and I will record that actually as a live broadcast in about a month. So at this point in time, if you have any questions, I appreciate your time. But if you have any questions, please reach out. This is my email address. Please reach out to me. Love hearing from you. Love to see some feedback from you. Does this work? Does this not work? Was this a good article? And in particular, like to know what your thoughts are moving forward, whether or not you think what we were doing here is good and it's helpful to you. I'll continue to post these on my YouTube channel, and hope you will partake in them moving forward. And please drop some feedback also on the YouTube channel as well. So other than that, thank you for your time tonight. Take care. I hope you read the article, and we'll see you on the next time around.